for whom, under what conditions. And importantly, a big sort of the history of health services research, a big question was always, and how much does it cost? And so cost effectiveness and cost benefits have been part of our field for years. And throughout the first several decades of health services research, the dominant frame was around cost, quality, and access, those three key aspects. And people used to say, you know, it's cost, quality, access, pick two, you can't have all three. We can argue that point. But in 2020, Congress, actually it was, I think, required in 2019, Congress asked AHRQ to support a report that the RAND Corporation actually conducted. And this was their results. The report is published in 2020. It's on their website. It's an excellent report. And you'll see that in this graphic, they talk again about sort of what are the input domains that we look at in health services research, and then what are the outputs? And they very much included equity. And so that got acknowledged, even though our field has a long-standing history of at least documenting health disparities, maybe not learning how to improve and address health equity, but certainly the focus on equity has existed and needs to be strengthened. Now, the report also identified gaps in health services research, and they also looked at primary care research, which is also legislatively in the original mandate of the Agency for Healthcare Research and Quality. And here you'll see that it really emphasized outcomes for a fuller range of populations, not just the average population, but really looking at diverse communities and settings, looking more at changes in how implementation affects healthcare interventions outcomes, the importance of communicating results, producing relevant and timely results, and then again using theory to connect findings and advance knowledge on healthcare change. And then they just started sort of presaging the current world we live in terms of digital health and how technology is really transforming not only how healthcare is delivered, but also our ability to study healthcare. And you'll see here a little bit more detail. Again, I point you to the report, but you can really see many gaps were identified in that report that need more attention from health services research. But I want to end this sort of, looking back part of my talk on this quote from Angela Bednarek and Vivian Sang, which said that the US research enterprise is famously well developed, but there is a mismatch between the research knowledge that is produced and the socially robust knowledge that is needed to address the challenges facing coming generations. So this mismatch in what we're producing in sort of the halls of academia and other private sector places where health services research is conducted, and what is needed to actually improve outcomes and health and quality and safety and costs, there is a mismatch. And so that is some of how I think the future of health services research needs to address those. But before I go into that future, I think it's really important to sort of address the elephant in the room. If you've been watching at all, or even trying not to watch, you know that this is a time of great uncertainty and indeed threat to the field to science and research and programs that have served for so many decades. So here are just a sample of headlines from various science journals. The Trump orders cause chaos at the science agencies, that RFK Jr. is taking a wrecking ball to health agency employees by firing thousands, that the devastating cuts to the NIH grants have been put on hold, but the change in the indirects, that the fear factor is reshaping American science as we see even private sector organizations that do not receive federal funding, canceling programs focused on diversity, equity, and inclusion, and already erasing words from their website. And of course, there's the global impact with a world without WHO, with America pulling out of it. And the growing number of federal agencies combing grants for taboo words. And then finally, what I want to end on, though, is I think a very important message from Stephen Wolfe that was in a recent JAMA Viewpoint. And this slide and the next are direct quotes from the article, which is, really focused on what we as a field in public health and in research need to do. And our profession, scientific, medical, and public health societies, academic institutions, and advocacy must decide how to respond or whether to respond. And how do we know where to draw the line and when it is time to resist? And he calls on us to always be at the touchstone of science and the evidence from rigorous published peer-reviewed research. And he pulls out examples of vaccines and their safety and their health benefit, of the impact of Medicaid in improving health outcomes. And he goes on about we must always focus on the science as our touchstone. And then he goes on to say that we must oppose partisan or ideological interference with independent scientific inquiry and decisions on research funding. We must oppose the censorship of data. As you know, many data sets that include more detailed and nuanced categories for gender and sexual orientation and race ethnicity were taken down. Some have been reposted, but they have been luckily been backed up by lots of people offline to preserve the data. And he ends on, regardless of the popularity or powerful interests behind a policy, the responsibility of the profession is to speak out when the science is clear that it will threaten health or safety, and that silence is not an option. And so it is with this context in mind and great anxiety about the current environment and where we are headed in science, but also as a country writ large, that I now focus on where I think health services research must go. And it must provide the evidence of the impact of these changes. Because we have beliefs about what might happen. I have the honor of being a member of the Standing Committee on Reproductive Health, Equity, and Society of the National Academies of Sciences, Engineering, and Medicine. And you know, we have ideas about what the Dobbs decision is doing to not just abortion access, but the health of women, the safety of maternal care, and you know, the impact on workforce. But we're only just now starting to actually document through research what we're really seeing and what that impact is. And so I think it's really important to stay focused on that role that we must have going forward. So now to dig into what I think is our three, not saying they're exclusive priorities for health services research, but certainly three priority issues and approaches to health services research that I think need to shape its future. And the first is for us to conduct equitable health services research. Now, I'd like to be able to give you a simple definition of equitable health services research. I haven't found the best one. There are various descriptions, but I want to start by quoting here. And if folks could mute themselves because I'm hearing some background noise. And quote here, Rachel Hardiman and her colleague, J-Mag Carbea, where they talked about in health services research, the evidence of Black-white disparities in health and healthcare costs have been acknowledged for decades, as I said. However, much of this work has been divorced from the social context of deeply seated racial oppression. Their words then say, read racism, that's not my insertion, that has created it. And they go on to say, without acknowledging the shortcomings within our discipline of health services research, we cannot identify solutions to the most vexing health equity issues in our field. And the authors go on to talk about how we must examine the questions we ask, how we frame our questions, the methodologies we use, including, for example, the data we use, and how you know, there's just this assumption, and I have done this myself, of course white is the reference group and the default, and everything else is other. So really questioning both how we frame our questions, and not always focus on a deficit model, but focus instead research questions on an asset model. And then finally, our interpretations of findings, and what do these mean? What do these results mean, and what has not been appropriately or adequately captured in the data? A race variable may just be measuring racism as a proxy, and it's not unpacked into the much more complex, hierarchical, multi-level forces that have shaped and continue to shape and drive inequities in our society. So from that quote, I want to move to also a few more points, because I'm going to really showcase a report that I think, if you haven't read it, I encourage you to read it. It just came out last year, this time last year, April of 24, almost April, by my colleague Margot Edmonds, and about a health equity roadmap and how to bring that equity lens to the work that we do. But first, I want to quote some of the authors that have been publishing and are really expert in this area. So you see here a group of authors who published in Health Services Research that it is insufficient to simply change the representation or diversity of the research team. Workplace climates must also affirm the positive contributions of increasing diversity and create conditions in which those from historically excluded groups can thrive. And of course, I look at that sentence and I think, how many of those words are now taboo in Washington? I mean, the reach, if we do not resist, is quite dramatic. But we also know from research based on decades of work to promote within academia, to recruit and retain and elevate a more diverse community of researchers, that it's not just about the individual interventions, it's very much about changing the culture of the institution. Then looking at one of our, what we say is the lifeblood of research, data, that building a data infrastructure without a racial equity lens and understanding of historical context will exacerbate existing inequalities along the lines of race, gender, class, and ability. Moving from that to, again, the variables, as I mentioned, this was from a report by, you see the authors here, but the important, it's really important. Treating communities of color as derivatives of whiteness elevates whiteness above all else. And we must be critical and mindful of how we integrate the concept of race into our analyses and our interpretations. And then finally, the chain of sort of research does not end when the research is completed. Obviously, it has to be published. And the academic publication process through authors, reviewers, and editors have legitimized scholarship that obfuscates the role of racism in determining health and healthcare. Or as I can't remember if it's in the same blog or another one, but there's actually, these are the gatekeepers of knowledge and our sort of collective body of understanding. And so they're another important point in really targeting how we think about health services research going forward. So this report that I started with was led by Margot Edmonds at Academy Health, and it lays out 10 steps. And I'm not going to go into any of these steps because I do not have time for that, but I really wanted to just highlight some of the aspects of it. So for example, the initial making the commitment to equitable research practices. And the report lays out for each of these steps a set of suggestions of what one could do. And then very helpfully at the end of each section, highlights a series of questions for investigators, researchers to ask themselves about their approach. Have they done certain things? So it's very user-friendly and provides a wealth of resources and references. Importantly, in terms of building your team and then framing your research question is very much the point, the sort of, I touch on it here, but the second part of the 3 directions, and that is engaged research with the population that you are interested in, with the community, the stakeholders involved in helping develop clear objectives and clear research questions. And then she goes on to talk about issues around, we think a lot about data just in terms of how do I manage these variables, which variables does it, and data quality, but what about governance? And again, that is a really important issue as well. And also when we think about data sources, the newer data sources that are also very much used in health services research, such as electronic health records, and now even a greater variety of data sources such as online search data and geolocation data, all kinds of different sources of data. What is the governance of those data? How are they protected? And how do you, as the researcher, ensure the security and privacy of those data as well? Since we know the more you find out about it, the data points you have, the easier it is to re-identify and cause harm if there are some bad actors at play, and we certainly have plenty of those. The last two sections and the last 4 steps in the equitable research roadmap really focus on the interpretation and then the giving back. The return of research results is a very important priority in the patient community. I had the honor of serving on the board of directors of the National Health Council, which is a national advocacy organization that brings together not all, but many of the patient particularly chronic disease groups that we know: cancer, diabetes, heart, hydrocephalus, many hundreds of organizations. And that return of research results to research participants, but also to the communities where you recruited your participants, whether those participants are individuals or organizations, healthcare systems, providers, stakeholders, that dissemination back and community engagement with the sources of the data is critical. And then importantly, pausing at the end of every research project that we do and really reflecting on our experiences and our personal learnings. And that time of reflection is important, not just to ensure equity and infuse equity into our thinking, but also all aspects of learning in conducting the research. So turning from equitable health services research to the second direction that is, I think, critical for the future of health services research is the one I already alluded to, and that is engaged HSR. And here again, there are multiple definitions. If you Google or do Google Scholar or PubMed, which I did just to kind of remind myself of how much variability there is out there, what is interesting is so many of them are specific to a particular, what I will call, stakeholder community. So this definition is derived from primarily actually the Wellcome Trust in the UK. But engaged research means embedding stakeholder perspectives across the entire research life cycle, which I've kind of already alluded to, from the agenda setting, the funding, and the research design through to implementation, monitoring, and evaluation. And I've listed some of the potential stakeholders, but let's see if you're listening. Drop in the chat some names of other kinds of stakeholders that you think are important to engage in health services research. And I'll be glancing over at my other screen to see what you've come up with, because there are lots of different stakeholders. So the question is, once we involve stakeholders, they bring their lived experiences, their needs, and their perspectives to each of these and more of the steps in that research life cycle. So we'd already touched on crafting the research question, but also understanding your stakeholders on how to collect data from them. So for example, not a stakeholder group you think of too often, but when at Academy Health, there's a large program now, it's 10 years old. It's the State University Partnership Learning Network. There used to be a California site, but there isn't, unfortunately, but they have 32 partnerships in 28 states or some number like that. And to really craft that program, we asked state Medicaid medical directors and other state policymakers what they needed in terms of evidence and support for making evidence-informed decisions, and that's how we designed the program. As you see, these others, co-creating interventions or programs is really important, and bringing in user-centered design and these newer methodologies that we've learned from the technology sector more. And then obviously any infographics or ways of disseminating information back out designed with specific cultures in mind as you think about your dissemination strategy early in your program. And then obviously finally the analysis and reporting, and stakeholders are important in every step that I've just gone over. Now, turning from the broad definition of stakeholder engagement to that of patient engagement. PCORI, if you're not familiar with it yet, is the Patient-Centered Outcomes Research Institute. There's a wealth of information on their website, and they've actually created, Academy Health was, when I was there, was very proud to help them first launch this, but it's a database of engagement literature. So they are accumulating the evidence on what the value of patient engagement in research and the methods of doing it, the lessons learned, et cetera. So, you know, there's a lot to know there before you, you know, that you can learn from as you develop your skills in engaged research. And they have these 6 foundational expectations or pillars. We've already touched on diversity and representation, the point of early and ongoing engagement. Too much of what academic community or academic engagement with community is transactional and late in the study process, or just for the purposes of getting a letter of support, and it's not authentic. And so that's really critical because that has a lot of benefits, as I'll touch on. That grants and research projects need to allocate funds to these projects. Why would a patient be expected to volunteer in research with no compensation for their time and effort when we, you know, are getting paid to do the research? It's our careers. The importance of building capacity to work as a team with the patient partners. And often in studies that I've read, the weak link in patient engagement is not the patients. They have been trained, they are prepared, they know how to engage. It's the researcher does not know how to work effectively and authentically with their patient or community partners. Inclusion in decision-making so that it's not just a consultative process, and then ongoing review and assessment of engagement. Because again, engagement requires at least 2 partners, the patient representatives and the researchers, and their experience of that engagement might be very different. So checking in and touching bases on whether it is producing both the expectations they each had and how it can be improved. Now, PCORI also lists the benefits of patient engagement, and each of these points is backed up by a first set of citations and references, so you can look at this. But it's important, they found that it improves study feasibility, acceptability, and quality, as well as relevance of the findings, which we think will enhance uptake of the findings into clinical practice once available. Because if it's not relevant, why should I change my practice? Or as a patient, why should I change my behavior? Researchers have a better understanding of patients' lives and clinical processes. Patients and other partners benefit from developing skills and contributing in a positive way. And with meaningful inclusion in decision-making throughout, this builds trust. And that trust with community, with patients, is actually critical in building a career-long engagement with communities over multiple research projects. So I think that trust building is so important, especially in communities that have good reason to historically distrust researchers. Now, another set of benefits of community engagement, this turning from patient to community engagement, this is from the NIH SEAL program, which is the Community Engagement Alliance. I don't know if this has been eliminated yet, but this is an important initiative. And they talk about community engagement helping to address health disparities, building trust in science, and improving health knowledge. So turning to my last of the 3 directions for the future of health services research, it is, I like to think first and foremost, all of the others are building towards impact. Because if we are an applied science in health services research, we are about improving health, individual health, community health, population health, and care. And so we need to have an impact. So what is research impact? Again, starting with some definitions. And here Again, I like some of the British ones, well, European ones the best. There are some good ones from Australia as well, where and Canada that has also been very active in this sector. But the first you see is an effect on change or benefit to the economy, society, culture, public policy or services, health, the environment, or quality of life beyond academia. So in other words, if it changes, the research changes academia, i.e. if we do good research, we might get more grants, we might get promoted, and we have a great career, right? But what's the impact beyond academia? The second definition actually includes academic impact as well as the economic and social impact. So as we think about impact, what needs to happen for impact to even have a chance? Well, first, people have to know about the research that needs to be disseminated, and we've talked about that. And the stakeholder community you are hoping will take it up, and it could be more than one community. It could be policymakers and providers or health systems. We need to understand what of their characteristics affect the research and their likelihood of using the research that you have produced. So here are 5 different levels of contextual factors that affect research utilization, not just the research characteristics itself, but the individual characteristics, the interpersonal, do you have that trusting relationship with the stakeholder? And do you understand the different values and incentive systems and the languages that are used across the research community versus the stakeholder community you are hoping will use your research to inform their decisions? Then there's the organizational. I mean, does the agency, the organization you're targeting, have the resources or capacity to use the research that you're producing? And then finally, all of the above are also affected by the current environment. And so, as they like to say in dissemination and implementation research, and the D&I conference, if you've ever been to it in December, is that, the context is king. Everything is about context. So being aware of that. And studies have shown that there are a number of different ways that we as researchers or the policy, research utilization, knowledge transfer community, those who try to bridge those two worlds, as I have done pretty much my whole career, that there are some strategies that have been shown in various studies to be effective. You can increase access to research. So obviously making peer-reviewed journals accessible to the stakeholder target audience you have. Improving their skills in reading even just the abstract or the one pager or the highlights to understand what is this research actually saying, what are some of its limitations, et cetera. Not that they're going to become researchers, but that skill improvement on how and when do I use evidence to inform my decision making. Systems improvement, again, that touches on the point I just made, that does the organization support individuals' stakeholders' use of the evidence, and so enhancing their organizational capacity, and then promoting ways to build interaction and trust between the research producers and the users. So, for example, in my career over various roles, whether at Academy Health or AHRQ, we would have various convenings where we'd bring some of the best researchers and knowledge, experts in areas to the table with our targeted stakeholder community to have a dialogue very specific and often behind closed doors to promote that kind of, what's it called, Chatham House rules dialogue. It's kind of Las Vegas rules, nothing leaves there. But those kinds of venues and other ways of bringing those together are really essential. And then what do we know about the impact of health services research? So I was fortunate to work with our colleagues at the National Academy of Medicine in 2017 for this workshop that was in late 17, early 18, and this report was published. I think it was a pretty good report. Even though I'm biased, obviously I was involved, but it acknowledged that there was significant impact on healthcare policy and the way health systems operate in the following areas, and you see the list there. But the report goes on to talk about efforts to focus more on that translation, communication, and implementation of results. and that especially needed, again, this is 5 years ago now, 7 years ago, get my math right, the importance of a deepened capacity and a broader vision of the capability of health systems research, that they called it that, and practice embedded in health-related initiatives throughout the nation. So that there was really that bringing, and in fact, at Academy Health, we ran one of these delivery system science fellowships in starting in 2012 for a number of years with colleagues around the country, to really build capacity within health systems to both produce and then use health services research directly connected. Within the VA, there has been a series of initiatives over the last, I guess it's 15 years now. I don't know if it's been cut yet, but they're called the COINS, and they're for collaborative research, where the VA-funded research, health services researchers work together with the operational leaders of the VA health system that they work in. And I was fortunate enough to co-chair the review committee twice, the first, I guess it was 2010 and in 2015, for the first two rounds of the funding for the COINS. So again, that concept of bringing the research closer to home to achieve all those characteristics of relevance and accessibility and stakeholder informed. The report goes on to mention 10 influential HSR studies, and some of these, I hope, are very familiar to you, and my slides are available for everybody, but obviously some that stand out for me is from 1972, right? Wasn't that the year? The health insurance experiment from Rand, classic. But how many decades later, the Oregon experiment and the effect of Medicaid on clinical outcomes, and more. And these are just some of, but highly influential individual studies that really changed both how we think about challenges, but also provided some evidence of what needed to happen to broaden the impact of those studies. And Rand, in that report I mentioned at the start, identified the following areas of impact. So they acknowledged the sort of scientific impact, building on the scientific base and changing how science is done, professional knowledge and practices, healthcare systems, policy, patient, and societal. So those were the domains of impact that Rand included in their report. And finally, importantly, the question is, okay, so we need to study impact, we need to get to impact, we need to understand impact, and then we need to measure impact. And so colleagues at Academy Health developed this framework based on reviews of a lot of articles that provide lots of frameworks, some of them very complicated on research impact, but a more simple set of metrics that the Robert Johnson Foundation could use to assess routinely in some of their portfolios the impact of the research they had funded. And you see some of the metrics here. So not surprisingly, peer-reviewed citations, great literature, academic presentations, those are sort of the bread and butter of maybe what the academic community thinks of as impact. But more important, as far as I'm concerned, is the top area where impact, those are influence, but impact really starts to come in when you are directly communicating or working with the policymakers and other end users to apply that evidence. And certainly these days, it's not just stakeholder evidence, policymakers at the federal and state level, but also in the courts, as we're seeing a lot of court decisions affect healthcare in America, not just the Dobbs decision. So those are some of the metrics of impact. And so to close with just a little time for some dialogue with all of you, this is obviously a time of great uncertainty and threat. I certainly have trouble sleeping sometimes, given what is happening. And it's hard to continue to read Blue Sky and all the newsletters and all the scientific articles, let alone the public media. But I keep reminding myself that evidence has and always will be my North Star. It is our North Star as public health professionals. And we must, as health services researchers, continue to conduct timely, relevant, equitable, engaged, high impact health services research. And that we find strength in each other and resilience by being in community and by acting. So with that, I'll stop sharing my slides and happy to take your questions or comments. They don't have to be questions.
Thank you so much, Lisa. That was fantastic. So much great information. Yeah, please chime in with questions either in the chat, or you can raise your hand or hop right in.
And yeah, universities as an audience, pharmacists, excellent. Yes, pharmacists, important audience. Religious leaders, yes, faith-based communities, very important. And state legislators, yep, not just the ones who are in agency executive branches at the state level, but yes. And then thank you, Svetlana, for the associations. They are part of, sort of, what's it called? The golden triangle of the special interests that influence policymakers. So you want to get your evidence into their hands. That's really important as well. So thank you for those ideas.
Will, I think you had a question. Go ahead.
Yeah, thank you so much, Lisa, for taking the time to share with us. I'm thrilled that so many students and others are able to be here today. You've been such a sort of passionate advocate for health service research for your throughout your career, both in terms of the quality research and the impact. So I just want to come back to how you started and ended the talk about the current climate, and we're worried about the integrity of research with data disappearing. We're worried about funding for continued federal data sets. We're worried about funding for researchers. We're worried about funding for training. HRQ has perennially been on the chopping block, and that's potentially going away. So, what do you say to students and others who are asking, well, what can I do to help advocate for the field right now? I mean, do you have any recommended strategies for working with professional associations who are out there lobbying for the field, et cetera? What's your suggestion?
Absolutely, is we have to raise our voices and push back. The courts can't do it alone. We have to get to the people who need to serve as the check and balance on what is currently happening and the very direct and existential threats to science. I'll just focus on the science aspects of what's happening. And so you sort of presaged what I was going to say, which is our professional associations. This is their job. And so whether it's mine, Academy Health, I would encourage all of you, students included, there are student memberships. I'm no longer the president and CEO, but I can't get it out of my blood. Sorry. Join Academy Health. Student membership is affordable. And they now have, Will, I'm sure you've seen it, their new situation report, which I think is a funny title for it, which is much more frequent advocacy updates because there's so much going on so fast that it's hard for any one person to keep up. But in addition to Academy Health, there's obviously the Association of Schools and Programs in Public Health with Laura Magana, who's a fabulous CEO there, and her team. Depending on where you're located, AAMC is in the fray, very much so. And APHA, I haven't seen them much on the research side, so maybe, no, you haven't either. So I haven't talked to Georgia Benjamin, the CEO, recently. But I think, and then there are other professional societies that I haven't mentioned for other disciplines. I'm not familiar with what they are doing in this space, but certainly this is not limited to health-related sciences. This is affecting, as you saw, every domain of science. NSF has been targeted repeatedly. Science at EPA, science at every agency, agriculture, USAID trials being canceled left and right globally. So it's pretty widespread. And so there is strength in numbers. So raising your voice through community and associations is a really important thing. And then our vote. I mean, who was it? Jefferson, who said, we get the kind of government we deserve, right? And the next chance to vote is in the midterms. So that will be my only political statement. I'm not a CEO anymore. I can say these things.
Thank you. There's a question in the chat from Svetlana. She says, I recently went to a conference where a lot of public health professionals agreed that we need to get on their level regarding language so that health and research initiatives are passed and listened to. Would love your input on this.
Yes, but I know you're always supposed to say yes, but I think this is definitely a but situation. So yes, we have always, if you're interested in your research being understood and used and having an impact, you must always use language that your target audience understands and can identify with. And there are polarizing words. And so you avoid those words. You always do. This has been the case my entire career. And so you want to go in with words that aren't necessarily polarizing. And I've had to sit, many years before the current time and talk to staffers or members of Congress with less than positive views about the Agency for Healthcare Research and Quality or the need for research or whatever. But you can still find usually some common ground. I've had certainly my experiences where you're not getting anywhere. So that's always, yes, you must use words that allow you to be heard rather than the words you want to say. But there is a limit to that. And I wish I had an easy answer to like, when is it not okay? And when is it okay? And I think that's really both something that's driven by your own personal comfort about where you as an individual draw the line and the context in which you're communicating. And so take the word equity, right? There are dimensions of, I'm trying to think again, I'm so used to saying the word equity these days. There are dimensions of care that are very different and that variations is what started the field of health services research almost. There are incredible variations in who gets what, where, and when. And you can use a rural health example. There are ways of framing the core message around not everybody gets the care they need in the way they should that get to the foundational principle of equity and better outcomes that maybe don't use the term equity. But that doesn't mean you stop studying equity. That doesn't mean you don't do equitable research. And so I wish I had a simple answer. These are difficult times, but I think it's very much evaluated on a case-by-case basis. What I don't think you should be doing, but it's easy for me to say because I don't run an organization right now, is eliminate the words from your reports and your research and these searching for taboo words. That to me is unconscionable, and it's being challenged in the courts, and we must stand up. And as Steve Wolf said, we've got to draw the line somewhere.
Thank you very much. Really, really appreciate that. Well, thank you very much for your time and being here with us. And I will share, if anyone's interested, the recording will be posted, and I can also share your slides. So thank you so much for your time, and we really appreciate it. Hope everyone has.
Well, thank you all for joining, and
good rest of the day.
Hang in there. You're doing a great. Public health is a great field. It's been my whole career. So,
great.
Bye.
Yeah. Take care. Bye-bye.